Welcome back to Take Care with Blair, a Mountain Health Co-op podcast that aims to bridge the gap between our members and the industry. And today on the show, we have Annie Glover. And before I let Annie give us her background, I did want to say, Annie, you and I worked together like 15 years ago, I think. I mean, that makes
15
me
years ago.
feel like
Yeah.
that makes us feel really old, but we had lost touch, went our separate ways in the world, and then both kind of found ourselves in this health space. But it was a few months ago that, those lazy kind of weekend mornings, I'm out in my front yard watering my plants. My neighbor walks out and is watering her plants. And she comes over to the fence and we're just talking. And she says, "Do you know Annie Glover?" And I'm like, "I actually do know Annie." And she's like, goes on to tell me that you spoke at a conference that she was at, and um, what you talked about was so impactful to her that she hadn't stopped thinking about it. And it had been a couple weeks since she heard you speak. And so that's like no pressure on you, Annie, but that's the word on the street about you.
That's pretty awesome because I'm an epidemiologist, and usually I think that's a little bit boring, a little bit wonky. And so if I was able to make an impact, that's really great to hear.
Yeah. It's a big deal. So give us, for our members listening, so this is a podcast for our members, those who at the co-op, of course, when you buy coverage with the co-op, you're also an owner of the company. And so for our members who are across our three states, Wyoming, Idaho, Montana, rural locations, tell us who you are and what you do.
So I'm Annie Glover. As I just said, I'm an epidemiologist, and really what that is we look at measuring disease, measuring health in the population. And I also am what's called a health services researcher. And so I look at health systems and health policy. So, how can we create systems that better serve people? How can we study those systems? How can we make sure that everything's in alignment or improve that alignment so that people get the services they need to be healthy? Um, so I'm at the University of Montana Rural Institute for
Mm,
Inclusive Communities. It's an independent institute at U of M. Our main focus is disability, individuals with disabilities, accessibility to healthcare services, inclusion of everybody in a community, especially in a rural community like we have across Montana. But my particular focus is mostly on maternal health, child health. I do some work in substance use. Um, and and yeah, I guess that's who I am professionally. So
So how, why, what inspired you? I guess, like, is there a moment in your life where you thought, this is where I want to go into, or did you kind of like fall into it kind of step by step?
yeah, I like to say it's the family business because my mom just
Mm,
retired as a public health nursing professor from at MSU Bozeman.
mm,
And so she was a public health nurse when I was growing up in Great Falls. And I learned about public health, thought it was amazing.
yeah.
She did home visiting. She did a
Wow.
lot of maternal child health work. My dad was a special ed teacher, and then my mom also worked at the School for the Deaf and Blind. And so we had a lot of, work with the disability community as well. And and so I always was interested in it. And I was also interested in public policy.
Yeah.
And so I started doing public policy, and that's how you and I got together.
Yes.
We were working together 15, 30 years ago, who knows,
Yeah.
in public policy in Montana. And I loved it. I love the debate. I love the process. And
Hmm.
I did that for a while, but then I really wanted to get into the evidence
Yeah.
and skill up so that I could do the math to really understand if these policies were actually working.
Yeah.
So get beyond the sound bites, get beyond the campaigns, but actually dig in and talk to people and find out, what is it that we can actually do to improve public policy. And so that's when I left my
Mm.
policy work and went to Tulane to do my PhD and got into academia.
Wow. I have so many, I have so many questions. My mind is, I'm like, but I guess if I was a member, my first question would be, what are some of the most pressing health challenges in our communities, rural communities today?
Yeah, I think that one of the most pressing health challenges that I think that we all kind of know is a pressing health challenge right now is behavioral health, access to behavioral
Yep.
health. And by that, I mean mental health. We have
Yeah.
significant mental health challenges in Montana, as well as substance use disorder. And
Yeah.
I think these are related to, the fact that we have a lot of isolation in our
Yeah.
communities. I think that we have some cultural issues in terms of, we're Montanans and we want to just be tough and take care of
Yeah.
ourselves and not show any sort of weakness. And that's been a hard thing, I think, for us to overcome. We don't have access to services,
Yes.
in a lot of places. People are driving, hundreds of miles for services.
Mm.
I grew up both in Great Falls and in Park City on a farm. We were
Mhm.
always driving into Billings for healthcare services, which was only 30 minutes on an interstate, but it was a lot still,
Yeah.
to be able to have to do that. And people are driving so much further. You know, um, if you live up in Glasgow, you're driving a
Mm.
ways for care, and you might need care every single week. Um, and so I think that those are two of the most significant issues. Um, Another issue I think is just access to high quality, consistent primary care.
Mm. Yes.
If we know from the evidence that if people have a good primary care doctor that they trust, that they see often, that they have better health outcomes because that primary care doctor manages the whole person. They
Yeah.
can get them into specialists. They can see if they're starting to exhibit symptoms of depression that they weren't exhibiting before. They can, you know, bring them, after they have a baby, they can
Yeah.
get them back into care, make sure that they are a healthy parent, moving forward. And if I could do something to really improve Montanans' health care, I would say it's to just fortify and double our primary care healthcare
Yeah.
workforce.
I think you're right on. And Montana, Wyoming, most parts of Idaho really struggle with having enough providers in that space. And the time and distance to get there, you're right on the money. How have you seen telehealth change the game, or have you really been tracking? I know you're tracking on a higher level, but not on the research level. I mean, what are you seeing with telehealth?
We started seeing a lot more with telehealth out of necessity after
Yeah.
COVID-19, during
Mhm.
COVID-19, as we all know. And I think that there's a lot of potential for telehealth. I think that there are some structural issues with
Yeah.
telehealth. So, the people that can benefit the most from having more access to telehealth might be individuals who are living in reservations or in very remote areas. They might not have the bandwidth or
Yes.
Wi-Fi infrastructure to use telehealth. Um, they might be people who have some more barriers to care in terms of health literacy, in terms of
Mhm.
just needing that live in-person relationship with a
Yes.
provider. And I think we have to be creative about how we do telehealth. We can't just move a regular appointment onto the telehealth
Yes.
platform. There has to be something else. Like, for instance, maybe we have providers such as nurses, nurse practitioners, physician assistants who are out in the rural communities and they're connecting with the specialist. And so
Mhm.
there's, some or care coordinators. There's a care coordinator or somebody live who is out in the rural community and they're providing support to somebody so they could come into an FQHC in their community and do their telehealth appointment there rather than relying on just doing it
Yeah.
in their house. So I think if we're creative and think about some hybrid models or, think about some ways to make telehealth actually work as a service extender rather than a service replacement, I think that would
Yeah.
be probably more successful.
I couldn't agree more. And I love telehealth for the convenience. If I'm starting to get a tickle in my throat or one of my kids, it's all call in. It's super, super easy. But when I want to go in and have that yearly visit, I want to look somebody straight in the eye. I want to be kneecap to kneecap, as they say. I want
Yeah.
them to be able to put their hands on my, my throat and
Right.
feel and listen to the way I'm breathing, because that's just how you build that trust. And it is hard because with telehealth, you never know what doctor you're getting. You never know where they're sitting, and they all have the qualifications, yes, but it's hard to build that trust that you need in the health space. So I agree. And I like how you said the service extender, because I fully agree with that. Something else that you talked about when you were kind of talking about what you do spurred my interest, because I think it has a component of public policy, but also what we're seeing as a challenge in these states, and that is maternal health. And
Mhm.
where I'm seeing it is we look at our members, and we have so many preemie babies that are either being flown out of Wyoming, and some places in Montana because there's not enough care, or they're being transferred to bigger hubs of care. We have members that are pregnant and live too far away to get care. So we have EMTs delivering babies. And then on the policy side, and this is my own, I don't think health should be a profit center. I think your
Mhm.
health should not be making other people money, but that's my own personal opinion. However, what we're seeing in some of our areas in these states are for-profit entities closing down care for maternal and delivering babies, and then women's care, because it's not a revenue generator. And for me, that seems like a public policy. I mean, if you're a hospital or you're a care system, you have to deliver babies. You have to take care of moms. And that's just I'm just curious what your thoughts are there.
I'm 150% with you on that. I don't like the profit motive in healthcare. I understand it. I
Yeah,
understand what it does. I think that competition is really great. I love
absolutely.
choice in healthcare and health coverage. I think that drives a higher level of excellence and innovation. But I think that that can be done while taking the profit motive out. And I
Yes.
think that there absolutely have to be safeguards put in place through public
Yes.
policy, because there are going to be some things that aren't profit or revenue generators.
Hmm.
If healthcare was all about profit, then we would be, all of our hospitals would just be doing bariatric surgeries all
Yeah.
the time. And that's not what people need. People need to deliver babies. People need to get care. Um, and the fact of the matter is that maternal health will never be a profit generator, for some significant reasons. Nearly half of deliveries in Montana are financed by Medicaid, and Medicaid
Oh,
just
okay.
naturally is a lower ratepayer. Um, and they're usually financed through a bundled payment. Um, and our birth volumes are really low. And when we have moms who have significant complications and babies that are premature, they do need to go to a higher level of care,
Yeah.
because we just can't have high level NICUs and high level labor and delivery in the rural communities. That just
Yeah.
isn't,
Not feasible.
it's just not feasible. We don't have the economy of scale to do that.
Yeah.
And so there has to be some public policy, support there. And we have to say as a society that there are certain things that we value. And I think that one of those things is making sure that people can have a healthy pregnancy, have a healthy delivery, and have a healthy baby. And that's
Hmm.
just something that we value and that we support.
Yes.
And we have to put funding into, and make some peace with the fact that we're not going to profit off of people's babies. So I I think that what we have to do in rural states, and we're talking with other rural states a lot with the Dakotas, we're starting to talk with Idaho, Wyoming is getting much more active in the maternal health space as well. But what we've been doing is giving some feedback to our national partners at the
Hmm.
CDC and at HRSA, which is the Health Resources and Services
Okay.
Administration. They do a lot of funding of rural health. And they do a lot of funding of maternal health. And we're giving them some feedback and saying, thank you for this tool that you created that works really well in Chicago. Very glad it works in
Yeah.
Chicago. It's not going to work for us in
Yeah.
Montana, in Idaho, and Wyoming. What we need are supports where we can assure people that they're going to get a high quality of care if they live in Shelby, that they can be pregnant and healthy in Shelby, that they can, let's say they need a maternal fetal medicine consult. Well, rather than having them drive down to Great Falls or over to Kalispell, maybe they can do a telemedicine, have this service
Yeah.
extender with the maternal fetal medicine consult, get their ultrasound done, in Shelby, and get their care as long as possible at home, and then go when they need to go deliver in the risk appropriate place when they need to, and then have a smooth transition back home where
Absolutely.
maybe they go deliver in Kalispell, and then their specialist provider in Kalispell is communicating with their primary care back in
Yeah.
Shelby and saying, okay, we have this person, they just delivered. Here's all of their paperwork. Here's everything that happened with this person. Here's the care that they need. Go out there and find this patient and make sure they get the care that they need rather than just leaving it on the shoulders of the person who just delivered. Um,
Yes.
and and providing that wraparound support and care that they need.
Yeah, and I think now that we're getting some of our HIEs, which are health information exchanges, established here in Montana, that's going to become an easier lift because right now not all the systems talk to each other. If you see care at one place versus another, the systems don't always talk to each other. Your information is not always there. And as somebody, a consumer of care, as we all are, it is so frustrating to go in somewhere and be like, I just told somebody this. I told them my health history, so I think that's going to be a positive streamline that we're going to see in the coming years. So what other things are you seeing in this space? What are things that consumers, members should be, aware of? What about us payers, health insurance payers? What are things that we can be doing to be helpful?
I would love to see more coordination, I think, amongst payers around figuring out how do we finance what I like to think of as the healthcare connectors.
Hmm.
To your previous point, care coordination and the continuity of care to me is one of the biggest issues that we have in the US healthcare system. And we see the symptoms of it not working over and over and over again.
Yeah.
Anybody who has a complex or chronic medical problem or issue can tell you that it is a nightmare to coordinate care across your different specialists. I was really involved with helping my grandma. She had multiple sclerosis and other complex medical issues. Uh, so I helped her, a lot with this care coordination. It was an area that really inspired me that I needed to
Yeah.
get into this. And it always astounded me that I could have as many degrees as I have and just be constantly bamboozled by the
Yes.
healthcare system. And I was
Yes.
always like, how do you do it if you're a single mom in, Forsyth and you're working a couple of jobs and you're just trying to make ends meet and you have a child with, severe asthma or a child with other,
Mm.
significant health issues and you're driving back and forth, you're trying to manage all of these medications, you're trying to manage all these therapies.
Mhm.
How do people do it? How do you do it when you have a substance use disorder?
Yeah.
When executive functioning is something that you're losing as a side effect of your disease that you're experiencing?
Yes.
How do you navigate the healthcare system? And so, something that I often say is that we know how to keep most people alive when they're
Yeah.
pregnant, when they're delivering. We have the technology. We don't need to invent some new surgery or some new medication. We know it, but people
Yeah.
aren't getting the care for whatever reason. They're lost to follow up. So how do we support those connectors?
Yeah.
And in maternal health, some of those connectors might be a community health worker,
Mm.
might be a doula,
Yeah.
providing that extra support during delivery. I think we've done a good job in Montana of standing up the peer support system for people with substance use disorder.
Yeah.
Those are care connectors, care coordinators, patient navigators. All of
Mm.
these are lower cost interventions that if we can put some money into these lower cost interventions, then we can prevent the higher cost
Yes.
escalation of care. And and we have to figure out a way to make it work for hospitals, for providers, so that
Hmm.
they're located there and make it and demonstrate that this is a reasonable and effective investment, to get more people just getting that
Hmm.
care earlier. We'll be healthier, the care will be cheaper. So it's a
Yes.
win-win.
Yes, and people live longer, healthier lives. Have you seen that Blue Zones documentary? It's on Netflix.
I haven't.
Okay, so he talks about what a blue zone, the long people have longevity in these little parts of the world. And one thing I thought, I listened to him speak at a conference I was at, and one thing I thought that was so cool that he talked about that was profound was in a lot of these blue zones, they are in poverty.
Mhm.
But the difference in their health and our health is that they have these care connectors. So they have somebody going into
Mhm.
their home a couple times a year and checking on the kids, checking, and the grandparents live with them, and
Mhm.
they just have that kind of hands-on approach with a trusted healthcare provider that's in the community, that connector. And that is, he said that's one of the main commonalities in these blue zones. So I think the care connectors is such a great way to invest our resources.
Mhm.
What are some of the biggest challenges you face when conducting this research in rural communities? I mean, it cannot be easy. We are a million miles wide and we don't have a lot of people. So, what are the challenges and how do you kind of go around those?
Yeah, so a big challenge that we always have in rural health is that there's few of us.
Yeah. Yep.
There's just a few people out there. And what that means in terms of research is that we don't have enough people to what we call powering a study, which just means how many people you need to have enrolled in a study to have
Mm.
statistical significance and to
Okay.
be able to show that the difference that you're observing is a real difference mathematically and not just a difference because of chance. And so that's always so hard in
Yeah.
Montana. Um, I do a lot of quality improvement work with the hospitals, and those are part of national initiatives. And so we'll get these tools and measurement uh, schematics, like ways to measure the
Yeah.
change from states like Florida, where they have 100,000 births in a year, and we have about 11,000. And so they can measure change quarter by quarter and say, look, we did this thing and look at these changes, and they have statistical significance where we can't measure it in the
Mm.
same way until we group everything together by like a 3-year average. And
Okay.
so it's really hard to measure in the same way that larger populations can measure. But that doesn't mean we can't measure it. We just have to use some different methods. And so we've started using a lot more qualitative methodology and started to look at patient experiences,
Okay.
patient stories, a narrative of, when they became pregnant or decided that they wanted to become pregnant through that whole journey, their pregnancy, their experience of care, what happened after. And I think that actually tells us a lot more because
Yeah.
with the quantitative, work, we can measure, okay, this population is sicker than this population.
Yeah.
But why? What
Hmm.
happened? Or we created an intervention and found it worked or it didn't work. Well, did
Yeah.
it work or did it not work because we didn't implement it correctly? Or did it not work because the intervention doesn't work?
Yeah.
You know, and we don't understand that unless we get in there and ask and see, oh, well, this is evidence based someplace else, or it's evidence based where they have, really strong care coordinators or something like that in the hospital, but it didn't work in this hospital because we don't have that system.
Yeah.
And people were just kind of falling through the cracks. So that's been a challenge. And it's also a challenge because since we have lower resources, we can't power studies as easy. There isn't as much rural health research that's published. And
Hmm.
so um, we're trying to fill that gap. We're trying to, start adding to the evidence for a very specific
Yeah.
population. But even doing that is hard because we just don't have enough doctors. We don't have enough
Yeah.
people in our health systems. And so when I want to go and ask them if they want to do some research, like, sure, with my 8th day in the week, I would be happy to
Yes.
do a research study with you. And so we just have to be creative. It's
Okay.
important to do it. It's important to get that data out there. But just being creative and figuring out what it is that we can do is important.
Okay, so that's the challenges. What do you see on the trends or developments shaping in kind of rural health, either care, research, or policy?
Um, let's see here. In rural health policy, I should have thought about this a little bit better. Something that we have been working on is figuring out how do we make it so that rural health systems, like a rural hospital or a rural FQHC, that they're sustainable and successful. And one of those ways that we've been doing this is that we've been out there talking to these providers, for instance, providers in rural emergency departments, and saying,
Yeah.
okay, are you seeing people coming in labor? You don't have a labor and delivery unit. Are people coming into your ED in labor? And when that happens, what do you do? Are you ready to meet that need? Um, and what we're hearing from them is that in these rural hospitals, people are coming in. I call them drive-by deliveries, where somebody's trying to get to Great Falls, but they don't
Yeah.
quite make it and need to stop at a critical access hospital. And so when this happens, these rural hospitals are experiencing a lot of fear
Yeah.
because they have really, really, really low birth volume. They're not seeing people enough. But when they see somebody come in with a delivery, it's an emergency situation and they have to, gather their resources and respond to that.
Yeah.
And so things that we can do are to have simulation trainings, for instance,
Mm.
in these smaller health centers so that they're practicing their skills and they're practicing that team-based approach and practicing their emergency preparedness so that when that person
Yeah.
comes in, they can be responsive. Um, we're starting an initiative this fall where we're working with the emergency departments to do things like making sure they have a written transport protocol. Um, because a lot of times what we hear from hospitals is that transport and referral relies on relationships with a
Mm.
referring hospital.
Yeah.
And that's not good if you have people who are locum or coming in and they're not working there all the time. There's a lot of turnover. And so having actual written policies and procedures are
Yeah.
really important. Making sure that they operate at the top of their scope of practice, that they're not trying to be a higher level birth center, but they have a really speedy response. If somebody comes in with preeclampsia, they can recognize it quickly and get them transferred quickly, and that it's a very minimize the stress on the patient, minimize the stress on the provider. So that's what we've really been working on is looking at, okay, if we can't have a labor and delivery unit in a rural place, what's the next best thing?
Yeah.
How do we have really smooth transitions? How do we have a really strong emergency
Yeah.
response? And how do we just maintain that over time? In the realities that we know where we have high staff turnover, we're never going to have specialists. We're never going to have hospitals that look like these larger hospitals. So how can they be the best small hospital they can be?
Yeah. I love that. And it also is going to take payers, providers, everybody rowing in the same direction. And I do think the misconception is that health insurance and hospitals like kind of fight it out and duke it out and are like adversaries. But at the end of the day, we're all trying to work together to have those checks and balances to make sure members are taken care of in the most efficient way for to reduce stress, costs on the
Mhm.
member. And so, yeah, it's just we have to continue to row that boat in the same direction.
Mhm.
Okay, two final questions, and I always like them to be fun. So, what do you do for fun or to unwind? What is a hobby?
A couple of years ago, I got a golden retriever. His name is Winston.
Oh,
He is my first dog, and I don't know what my personality was before I had him because my personality is fully Winston now. And so I hang out with Winston. He's a delight. He's afraid of everything. We were walking one day and he was afraid of a watering can.
oh my God.
It was alarming. My mom has a golden retriever named Harriet, and she's the opposite. She is not afraid of anything. She's a little bull in a china closet, and they're best friends.
Oh,
And so I would say mostly golden retriever time is what I do for
yeah.
fun. I mean, there's the usual reading and travel and all of that,
Yeah.
but what I like to do is play fetch with Winston, hike with him,
Oh,
so
dogs seriously are the best. Everybody should have a
yes.
dog. Okay, here's your last question. Would you rather? So would you rather go back in time 100, years to create policies that would impact today, or would you rather go ahead 150, 100 years, 150 years to see what changes have occurred based on some of the things that you're helping put into place now?
I would rather go back
Okay.
100 years, and I would like to change the trajectory um, that I think started in the, around the 20s and 30s, where at some point in the United States, we decided not to have universal health care.
Mm-hmm.
And I would change that. And I think that so many more people would be healthier
Yeah.
today if we had chosen to go with universal health care. And that could have looked like anything. It could have looked like a national system. It could have looked like a whole bunch of co-ops, for instance, that are covering people. It could have been a private sector, intervention, whatever, So I'm not saying create a national system necessarily, but everybody having access, guaranteed access to healthcare.
Yeah.
That's what I would change.
Mm, I love that. Well, Annie, thank you for being on the podcast. Thank you for continuing to fight the good fight and serve the people of our state. I appreciate you so much. Thank you.
Thank you so much, Blair.